Welcome back to the Continuing Professional Development Program in Applied Clinical Ethics for frontline healthcare professionals at the MUHC. In this second segment, we will go into greater detail about our philosophical approach and the analytical methodology used by ethics consultants in helping you arrive at the best decision possible. Typically, when we get a consult, the ethicist gets confronted with two action requests. We have a choice: intubate, don't intubate, admit to the ICU, keep in the emergency room, withdraw life support, keep life support, put the patient on the transplant list, keep him off the transplant list. The challenge for the clinical ethicist is to take those action tensions and to expose and identify and elaborate on the underlying ethical components of those tensions, after doing a full analysis to guide you back to the best action solution we can come up with. So, how can a clinical ethicist help you? One of the first things a consultant can do is to provide you and guide you through an analytical methodology on how to analyze and solve the problem. It's a 4-step process, which is deceptively simple. It seems like a generic problem-solving approach. You start off with a question, you work your way through until you come out with a specific recommendation and solution. But it's not that easy to apply it to the complex, sometimes muddy reality of frontline clinical care. In our experience, the most challenging step is in fact the first step. And what we ask you to do when confronted with a clinical challenge is to reframe that clinical action challenge into identifying the underlying ethical dilemma. Well, the first question then is, what is a dilemma? And surprisingly, people don't always get that right. A dilemma is not a choice between right and wrong, between good and bad. Think of it, who would actually opt for the wrong choice or the bad choice? That's not what a dilemma is. More typically, a dilemma is a choice between competing goods, or on a bad day, between competing bads. So the goods may be values or principles we adhere to, but there are some that come on both sides of the equation, and how do you balance those out? Sometimes these values seem to be in competition. Which one wins the day? So if we go back to the clinical vignette I raised in our first segment, you could argue that patient autonomy, respecting patients' wishes, is a very important value in our society, and that's true, and we do everything possible to respect that. At the same time, the professional values of caring for patients, working in their best interest medically, beneficence, those are also critical. In that case, it appeared as if those two were in tension. They're both good. How to resolve that tension? There is a good example of an ethics dilemma. In the hundreds of ethics consultations we've done, I think it's fair to say we can group them into one overarching ethical dilemma. On the one hand, again, we really try as much as possible to work in the context of respect for our individual patients. Patient autonomy, personal values are very important. They're crucial. We also have to have respect for the expression of cultural and religious freedoms and differences. As I said, we are living in a pluralistic society. That is often, however, in tension with professional integrity of our healthcare providers, doctors, nurses, social workers, respiratory technicians, pastoral care, and all the other allied healthcare professionals. We are bound by our codes of ethics, which say, try to do the least harm possible. Don't add another layer of harm if you're not going to do any good. Practice according to established patterns and standards of practice. Invoke conscientious objection if you're asked to do something which you think is really morally repugnant and wrong. And of course, more recently, we're expected to consider distributive justice in the allocation of scarce resources. So those are all good values, all good principles, but in certain cases you will see inevitably, and I'm sure you've experienced this already, where they appear to be in tension. Well, this isn't as easy as it may sound. In our experience, very busy clinicians often say, well, I understand the concept, but I still have a hard time actually identifying or articulating these dilemmas. Can you give me examples so I can wrap my head around these? And so we're going to provide you with a partial list of the kinds of more typical dilemmas you are likely to be facing on a daily basis. In my experience, however, it's not that easy to always identify and articulate what the underlying ethical dilemma is. Busy clinicians typically are action-oriented people, and so to ask them to stop and find the underlying ethical components can be a real challenge. That's why we're providing you with a very partial list of typical ethical dilemmas you face on a daily basis to help you start approaching some of these cases. The most common ones are the tension between respecting patient autonomy on the one hand and adhering to professional standards of practice, doing the right thing according to professional integrity. Sometimes there's tension between professional beneficence and non-maleficence, doing as much good as possible, but also avoiding providing any additional harm. Sometimes there's tension between what's in this individual patient's best interest and what's socially fair. Is it okay? Is it ethical to spend millions of dollars on high-tech care for a patient literally in the last few weeks or months of life, for example, is a valid ethics question. Sometimes there's tension between respecting patient confidentiality and yet having a duty to warn third parties who may be affected by the decision. There can be tension between the preservation of life on the one hand and alleviating of suffering on the other hand. Two may be in competition or seem to be so. And one other one I will mention just now, obviously we're there to work in our patient's best interests, but sometimes we wonder whether there are limits to that in terms of us also worrying about protecting ourselves. Life at the front lines of clinical practice can be very complex, very muddy. It's rarely black and white. It's rarely right versus wrong. And so the ethics of this is not like a light switch on or off. It tends to be more on a continuum. Probably a more helpful and constructive approach would be to see this as having the ethicists help you identify a range of acceptable options. There's a continuum. Obviously, at one extreme are those we can identify as unacceptable, not ethically valid. And at the other extreme, we can identify those options which are ideal, which we may not be able to implement because of restrictions and resources. But between those two, there's often a range of options, all of which are ethically defensible. And the question is how reasonable people can reasonably disagree but still come to a consensus on what's the best option. I'd like to go back now to that image we had in the first segment of that Gordian knot, that tangled web of complex issues and how to untangle that effectively, efficiently, and the best way possible. And another way of approaching this is how can the ethics consultant help you do that? One of the ways we can do that is to try to identify all those various threads and tangled elements. Give them names so that you can relate to them. Are we talking about patient autonomy? Are we talking about social norms? Are we talking about legal restrictions? Are we talking about clinical indicators? Cultural norms, conscientious objection. Those are all elements that need to be carefully dissected out and identified and articulated. But probably the most important skill set that the ethicist can bring to the bedside is to apply the whole host and range of philosophical perspectives that an ethicist typically is trained in. There is more than one, and the job for the ethicist is to use all those tools at their disposal to bring those perspectives, that ethics lens, to bear on that complex web, on that Gordian knot, to help us analyze and come up with a recommendation. So to summarize, what are some of the things that clinical ethicists can help you at the front line? When we get a call, we often sense that you, the doctor, you, the nurse, you, the social worker, feel a deep sense of moral angst. You may not be able to identify the source of that angst or articulate where the competing values or principles in play. The job of the ethicist is to support you, to help you identify the source or sources of that moral angst. We are there to help identify and articulate the ethics component of a clinical challenge. We can also provide you with information and clarifications of various professional, cultural, social, and ethical norms and guidelines that you probably don't have time to learn and apply on your own. We're there to help you untangle what may seem to be an overwhelming sense of competing values and principles and ethical arguments. We can help identify in that context a range of acceptable options. We can help prioritize that range of acceptable solutions. And then often we can help actually mediate a consensus solution that provides support for the team, for the patient, and for the families. I'd like to finish off by getting back to the clinical case vignette I started off with in the first segment. People often know, well, how did actually the case turn out? We were very fortunate in that the patient within the next few minutes actually did consent to life-saving C-section. As the obstetrician started doing the incision, it was clear that the patient actually did rupture her uterus. We were fortunate to be able to save the patient's life as well as the unborn child's life. And everything in the end worked out well. But we literally came within minutes, if not seconds, of having a dead mother and a dead unborn child. What I found particularly striking is I went to visit the mother about 4 or 5 days after this. As you can imagine, the doctors and nurses were quite traumatized, as was the patient, with this whole ordeal. So I thought it was important for me to find out what was actually going on there. What did we miss? What did we get wrong? What could we have done better? Interestingly, the patient looked at me and said, "I'm still very angry with you and the team." I thought she was saying that because she felt we had violated her autonomy, we hadn't respected her wishes, her cultural norms. She had recently immigrated from a foreign country where she came from with different expectations of the healthcare system. And so she actually said to me, "You call yourself a doctor? Where I come from, doctors and nurses save lives. It's okay for a patient to say no, 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 but surely you shouldn't have stood by and waited and watched while I bled out to death." The moral of the story here, from my perspective, is while nobody has a crystal ball, we realize now that probably the idea of standing by and watching this mother die and her unborn child die was not likely the best ethical path or outcome. Yet at the time, those seemed to be, at first glance, the obvious ethical and legal norms to follow. What I'm trying to say here is it requires a more nuanced and sophisticated ethics analysis in critical cases to help us navigate these complex waters. And hopefully an ethics consultant could help support you in that endeavor. Lastly, I'd like to share with you the kinds of topics we intend to cover in an upcoming series of podcasts, which is the continuity of this program in applied clinical ethics. Topics we intend to cover in the next few weeks and months include shared decision-making. What is the partnership involved in the consent process? Secondly, the goals of care and levels of intervention. We find that people often get confused of what those two terms are and how they interface, and yet it's extremely important to know to distinguish those two and know how to use them. A really important one, which I think is critical and on everybody's mind these days, is moral distress, moral residue, and burnout. And what are the survival strategies of having to deal with what is unfortunately a very common occurrence at the bedside for our healthcare professional these days? And last but not least is a podcast on a session for distributive justice and allocation of scarce resources. The COVID-19 pandemic certainly brought that topic to the forefront. I really hope that exploring these topics and others in the coming months and years will really be practically helpful for you at the front lines as you continue to face the challenges of clinical care for your patients and families. And please remember, you always have access to the resources for ethics at the MUHC. Thank you.